And should I just say next slide when I'm ready? Excellent. So just an next slide. Just an overview of what I'll be speaking about today. I'll be talking about the diagnostic care gap. That is kind of showing where we are in terms of our diagnostics and our ability to diagnose tuberculosis.
सोनी मैडम हो कर ले सपोर्ट 604 है अब मेरा
Dear students, please switch off your microphone, okay? Mute.
Then I'll be talking about latent tuberculosis molecular testing. This is when the TB, you are infected with the TB, but you are not having active symptoms. So we'll be talking about T-spots and quantiferons. Sorry, I'm speaking in short fragments because my understanding is somebody was going to translate after each spot.
All right, it's okay. I think you can go on. The audience will read the text and you will just speak in English.
Got it. Okay. I apologize. I misunderstood. I'll just keep presenting in English and pause me when I need to slow down. After that, so let me start over on the slide. So here's an overview of what we'll be talking about today. Back one, please. So I'll go over the diagnostic care gap. I'll go over testing for latent TB disease. This includes IGRAs, the T-spot, and the quantiferon. I'll then talk about active TB testing. So this is when you have the TB in your system and it is causing symptomatic disease, the most common of which is pulmonary TB. We'll talk a little bit about PCR, since this is a common way we do molecular testing. So just making sure everybody understands that. And then we'll talk about expert, LPA, LAM, and sequencing, which are all very common molecular tests for active TB. And then we'll talk a little bit about future directions of TB testing. Next slide. So, tuberculosis is the #1 infectious killer in the world. It has killed more people over time than any other single infectious agent. It is extremely old as a disease. So when you look through history, it is still a very big problem, even today. Next slide. So this kind of asks the question, why? If this is a disease that has been around for so long, why is it still such an issue? Why is it still such a problem when we've seen it for such a long time? Next slide. So there are many reasons for this, and there are many points after a person has been diagnosed, after a person has tuberculosis, that we can kind of miss them. And one of those is gap 2, when we look at a patient care cascade, which is that they did not get diagnosed with the tuberculosis. So even though they have TB, they're out in the world and we do not know it. We are not appropriately testing them. They're not getting linked to a place that they can get a test to find out that they have TB. Next slide. So gap 2 diagnosis is what I'm going to be talking about today, and specifically molecular testing that we can do. So there are many kinds of tuberculosis tests that we can do to try and make that gap 2 smaller, that we are missing less people that have TB out there and do not know it. Next slide. There are many ways to diagnose tuberculosis, whether it's active and they have symptoms from the disease, or whether it's latent and it's in their body, but not quite awake yet. So chest x-ray, looking at the sputum, called the acid-fast smear, and looking at it under the microscope and seeing if we can see tuberculosis. culture, taking that sputum and culturing it to see what grows, and then PCR, which we'll talk about. And then you can see TST, which is the skin test. As you can see, these different tests have different sensitivities and specificities. So the point is, we still don't have the perfect tuberculosis test yet for diagnosis. Next slide. Molecular tests are very much needed because in addition to the slide I just showed you, sensitivity and specificity in children for tuberculosis is even worse. So it's very difficult to diagnose children. And depending on how much TB you have in your lungs when you cough it up, it's hard for some of these tests to work. If you can think about it, when you cough up some TB from your sputum, if there's not much there, you're not going to get a good culture. You have to have enough TB to culture and be able to do testing on it to know what drugs are good. And this is why molecular tests can be very, very helpful, because they can often test TB from different patient samples when there's not a lot of TB that is alive. Next slide. So there are many different molecular tests that have been developed and are out there and available for use. They have different advantages and disadvantages. So we'll talk about some of the ones today that are the more common ones that are in use. And this is to give you an idea of what people are using and also give you an idea of why there's still no perfect test, but maybe we are getting close. Next slide. So the first tests I want to talk about are for latent TB, or when you have TB infection. So this is when you have TB in your body, but it is not causing active disease. I work with children a lot, and when I talk to them about latent TB, I tell them that the TB is in their body, but it is sleeping. It is not causing them a problem this moment, but if we don't treat it, then it can become a problem. So the way that we measure this is that we look and we see if the body is having an immune response to TB, because it's hard to find the TB when it is not active in your body. So what we do is we say, well, is our immune system responding to it? Do we see that the immune system is recognizing the TB and trying to fight against it? So there are two tests in this category that we use often. They're called interferon gamma release assays, or IGRAs, you will see them called. One of them is called the T-spot, and the other one is called the quantiferon. Next slide. So the reason they are called interferon gamma release assays is because we are actually measuring a molecule called interferon gamma. This is released by your immune system when it has seen TB inside your body. So you can see here, it is a blood test. We take blood from the body and we can do either the T-spot or the quantiferon or both. And they're looking at the body's immune response, how it's creating interferon gamma in response to the TB in the body. Now, this tells you if your body is reacting to the TB. But as you can see, this is not telling you if the TB is active in your body. So if the TB is active, you may still have a positive IGRA test. So this is good for us to know the person is responding to TB, so they have TB in their system. But it doesn't tell us much about the TB. So we don't know if the TB has any drug resistance at all. And we don't know what medicines would work to treat the TB if the TB is there. So it is a very helpful test to know that the person has TB in their body, but it has some limited information as well. Next slide.
Aline, sorry, because I was
It is the Zoom way. It is the Zoom way. Next slide. So there are some small differences between these tests, and I don't want to go into too much of the details between them, but really, you can use either of them. Some people feel that the quantiferon or the T-spot has a little bit better sensitivity in certain populations, that it's better to pick up TB in certain situations or populations, but they are pretty interchangeable. So you can use either the quantiferon or the T-spot. Both of them are able to give you an answer in a few hours, whether you have TB in your system. And they both measure interferon gamma, whether it is being produced by the cells or the number of cells that are producing the interferon, or the number of cells that are making the interferon gamma. And they give you a result, and they interpret positive, negative, or indeterminate in the case of the quantiferon, or in the case of the T-spot, positive, negative, indeterminate, or borderline. And often if you get a borderline example, you will do a repeat of the test. Next slide. So, molecular diagnosis for active TB. So either you got TB and now you have active disease, or you had latent TB and it has become activated. So now you have symptoms. And the principle behind testing for active TB is that you're taking DNA, the genetic code of the tuberculosis, and you're analyzing the sequences that can identify the presence of it. So you're looking for pieces of the DNA of the tuberculosis from a sample from your body, and you're trying to use that to say, I think I have TB here. The nice part about molecular diagnosis is, since you're looking at DNA, you can also look at the sequence of the DNA, and you can see if there are markers called mutations. There are differences from what we would think of the sequence would be normally, and say, aha, because we see this little mutation here, or this change here in the DNA, we know that certain drugs will or will not work against this tuberculosis. So this is a really nice aspect of some of our molecular tests that can give us information. Next slide. The World Health Organization has been working hard to put together a catalog of these different mutations or these changes in the tuberculosis DNA that tell us what drugs will and will not work against the tuberculosis. So if we look at the tuberculosis DNA and we see mutation at this region, we can say, okay, I know this drug is not going to work anymore. So I need to change the treatment plan I would have used for this patient. Next slide. So that asks the question, well, how do we actually know what DNA is there? So many of our molecular tests are based on PCR. So this is polymerase chain reaction. And what this does is you are looking for a piece of the TB DNA. Let's say you have had a patient cough up a sputum sample. So you have some sputum in your cup. And essentially what you're doing is you're trying to find any small piece of the TB DNA in the sputum. And once you have a piece, you want to make as much of it as you can. The more of it you can make and kind of replicate or make more of, then you can do testing on those pieces to see what information they have. So the way this is done is you take things called primers, and you say, I want to look at this particular piece of the TB DNA. I want to look for this particular spot, or I want to look for this spot and this spot and this spot. And as you can think, the more of the DNA of tuberculosis that you look at, the more information you can get. If you're looking at just a small part, you're only going to get the information about that part of the DNA. But if you look at many, many places, you'll get more and more information. And then if you look at the entirety of the TB DNA, you'll have all the information of the TB that you would like. So PCR is going to be used in many of our molecular tests, looking for those short pieces of DNA or long pieces of DNA of the tuberculosis in the different samples. Next slide. So expert, there's MTB-RIF and MTB-RIF Ultra. These are both highly used throughout the world right now. These are very, very convenient. So it is a small cartridge and you put a sample in it. Right now, expert can be used on sputum, but it can also be used on stool or poop from individuals. And you put the TB in the cartridge, and then you're able to put that small cartridge into the machine. And in a matter of hours, it can tell you, yes, there is or is not TB DNA here. It is seen. And it can also tell you a little bit of information on what drugs are going to use. So in this case, for the MTB-RIF and the MTB-RIF Ultra, it tells you if there is a mutation or change in the DNA area for rifampin. And so it can tell you if it thinks that rifampin, the drug, is or is not going to work against the TB that is in this patient's body. So as you can see, it's very convenient. You do need that expert machine to be able to run this. The cartridges can get pretty expensive, so that is a disadvantage to this test. But in terms of usability, it's very nice and it does not take a lot of preparation. Right now, the World Health Organization has said that you can use expert on sputum, but you can also use it on stool, particularly in children. If you think about it, it's very difficult for a child to cough up a sputum sample when they're 3 years old and you're asking them to do something. So the fact that we can use stool is very helpful. And the next question I get is, well, if a child has TB in the lungs, why am I going to see it in the stool? When we are sitting, we are coughing up sputum often, and we are swallowing it into our digestive system. And children are doing the same. So while if we ask them to cough up a sample, they are not able to do it, all throughout the day, they are actively doing little coughs and then swallowing it into their digestive system. And so then it shows up in their stool. So this is a really nice option for stool or sputum. And it gives us information if we're able to see tuberculosis in either of those samples and whether one of the drugs, rifampin, works against it. Next slide. So the thing that I like to point out about expert is how fast it is. And so once you have a sample in hand, you can do the expert test and you can get your answer in a couple of hours. Whereas usually you would have a patient come in, cough into a cup, look at it under a microscope, and then you would try to culture it. And culturing tuberculosis takes a very long time. This can take weeks. So this is weeks in which you don't know, is the TB going to grow or is it not going to grow? And once it does grow, is rifampin going to work against it? So this is a same day or next day test that you can get to help, try and help answer some of these questions. Next slide. So as I mentioned, there's 2 versions of expert that you'll often see. There's a third one we'll talk about in a minute, but the 2 that you'll see is MTB-RIF and MTB-RIF Ultra. And so some people may ask, what is the difference between those 2? And the difference is that the Ultra is more sensitive. They did a very large site study and have continued to do some studies that show that there's a higher sensitivity with Ultra, but a little bit lower specificity. And so, and the detection for rifampin is often around 100%, depending on what mutations or changes in the DNA you're looking for. So this is a very nice test in certain locations. Next slide. So there's a new version of expert, which has come out, which is called the XDR. So this works the same as the other 2 expert tests, where you use a cartridge and you put the sample in the cartridge. But this now looks at more mutations. It looks at more areas of the TB to see if there is a mutation for resistance for these other antibiotics. So in addition to rifampin, and very commonly used drug for TB, it also looks for isoniazid, some fluoroquinolones, amikacin, and ethionamide. So this gives us even more information within about a day about what drugs might be used against this particular tuberculosis that this person has. Next slide. So line probe assay. So this is another molecular TB test that we'll be talking about. We can also call it an LPA. This test uses the same concept of amplification, so PCR. So it takes the DNA from a sample, you isolate it, you amplify it, and then it used these little things called probes to try to find different pieces of the DNA and tell you a little bit of information about what drugs would work on it. And I'll show you a picture of what the test looks like in just a moment. But this does have some advantages. It has a turnaround time of 1 to 2 days, so it's relatively quick. It has really nice sensitivity of 99.2%, but the specificity is pretty low at 26.9%. And this can be used on sputum directly, or it can be used on sputum culture. Next slide. And this is what the test looks like. As you can see, there are these little strips, and you can line up the strips. When I look at this, I think of it a little bit as a urinalysis test when you do the dip with the strip and you can see the different pieces. This reminds me of it a little bit. But you can see the strip and where the lines are, and then you will have a reference for those lines that tell you, okay, this is the piece of DNA it sees or does not see. And then you're able to interpret of the drugs that are being tested, which ones will work. So in this case, you can see along the right side of the picture on the left, it says some things like RPOB, CATG, INHA. These are different areas of the TB genome that can have mutations that tell you what drugs work. So for example, RPOB, that is an area where we get information about the drug rifampin working. Or CATG and INHA, those are areas of the TB genome that tell us if isoniazid will work against it. So this can be a helpful test. Next slide. So this is a molecular test that is helpful to tell us whether TB is there or not, but it does not give us any information about what drugs will work against it. So this is a loop-mediated isothermal amplification. It's very quick, a 1-hour turnaround time, and it's an easy visual interpretation. So you can see that you have your sample, and there's a very distinct color difference. In fact, when you put it under a UV light, if you have TB, your sample is going to light up a neon green, and if you don't have TB, it will not light up. So it's very user-friendly. You can train somebody who does not have a lot of background to easily say, yes, the tube is glowing, so there's TB there, or the tube is not glowing, so we don't see TB there. This only works on sputum, but again, it's very fast and it's very easy to interpret, yes, I do or do not have TB. Next slide. It is a very simple workflow. So again, it's very easy for somebody who doesn't have a lot of experience in a lab. You can process your sample very easily in a little tube. The DNA gets extracted. You put it in the incubation, and then you look at it under a UV lamp. And then the last picture you can see, it's very obvious, again, what is glowing and what is not glowing. So easy to tell if you do or do not have TB. But again, no information at all about what drugs will work against the TB. Next slide. So LAM test. So this test is very interesting. We actually do this test on urine samples. So it's easy to get a urine sample from an individual. It's not as difficult to ask them to cough up a bunch of sputum. Most people, if they are at the doctor's office, are able to give you a little bit of urine if you ask them to. But once you have the urine, the sensitivity is often not very high for this test. So there are a couple versions of the lamb test out there, for example, Fuji lamb or Alere lamb. And you can see that the sensitivity is kind of low. So 70% or 42%, you're missing a lot of cases if you were to only do the lamb test. But because it's on a urine test and that's an easy sample to get, we do still use it. And we often use it as a test in individuals with HIV as a rule-in test. If you have somebody come in and you really think like, I have a high suspicion, I really think this person has TB, this test can tell you, yes, you are correct. If the test is negative, maybe it is just missing it. But if it's positive, okay. I was pretty sure they had TB beforehand. I'm ruling it in. I am confirmed in my suspicion. Next slide. So sequencing is one of the areas of molecular diagnosis of TB that I'm most excited about. And this is the area that our research group works in a lot. So there's a lot of different kinds of sequencing out there. And sequencing is looking at the pieces of the TB genome, the TB DNA, and telling you the exact makeup of them. So telling you what nucleotides it sees and then what proteins are there. So there's whole genome sequencing, and this is done only from sputum culture. So you have to wait those 1 to 6 weeks for the TB to grow to do whole genome sequencing. You can look at all of the TB genome and get all of the information from all of the different areas, but it takes some time. Targeted sequencing, in contrast, is when you're only looking at particular parts of the TB genome. So you're not looking at the whole thing, but you're saying, I have 15, maybe 20 areas that I'd like to look at because these are the most important to me. So I'm going to target these areas and get information from them. With targeted sequencing, you can do this from direct sputum. So somebody is coughing up some sputum the day they come into your clinic, or you can do it from stool. So this is very nice. You can do it on different samples and you can get more information that day. We are working with a certain kind of targeted sequencing in which after the patient gives you the sample, it takes 1 work day for you to do your targeted sequencing and have information on all the areas that you were looking at, which is very fast. Whole genome sequencing is more expensive compared to targeted sequencing because with whole genome sequencing, you're looking at the entire TB genome versus just some areas. In terms of the workflows, whole genome sequencing does take more time. You also need individuals that have a lot of experience with bioinformatics. It's a lot of data when you're looking at the whole TB genome. So you need to know what to do with that data. So you often need somebody or a group to be able to give you that information. And then there's also different platforms. There's different sequencing machines with different costs. There's one machine out there called the Wona that is only $1,000, but then there are machines that go up to $30,000 and $50,000 US. So there's a big range of the amount of money you can spend on a sequencing machine. And as I mentioned, depending on what kind of sequencing you're doing, you can do it on different sample types. Next slide. So again, this is just a little overview, a little bit about the kinds of sequencing. In the middle, you can see targeted sequencing. So that circle is the TB genome. So with targeted, you're saying, I only want to look at these specific areas. These are the areas that are the most important to me. And so I want to look for the mutations in these areas, these changes, and I can then look at the WHO catalog and say, do I see mutation here? And does this mean that this drug is going to work or not? And then on the far right, you can see whole genome sequencing where we're looking at everything in the TB genome. And so you know all the information that you'd like to know, but you can only do it on the sputum culture after you've waited for many weeks. And it is more costly, it's more time consuming, and you really need more support from somebody who knows bioinformatics to interpret the information. Next slide. So I already talked about this a little bit, but this to me is what kind of brings it together in terms of understanding short read and long read. So when you think about all these different areas of sequencing that you're looking at, if you're only looking at small pieces of DNA, it's harder to put it all back together. I like to think of it as a puzzle. If you have a puzzle that is 9 pieces, it's easy to put the pieces back together and not make a mistake because you have these big chunks of data, it easily goes together. Whereas if you're only doing smaller pieces of sequencing, you know, like a 1,000 piece puzzle that you're putting together, it's very easy to make a mistake and it takes a long time. So we do have computers that help us put these puzzle pieces of the DNA back together, but it still takes the computers longer to do a 1,000 piece puzzle than it does a 9 piece. So the longer pieces of DNA you can get, the easier it's going to be for you to put it together and the faster it's going to be, and the less likely you are going to make a mistake. Now for TB, there are some, whoops, go back one, sorry. I'm still talking about the puzzle. For TB, there are some areas of the TB DNA that get kind of repetitive. So it's the same nucleotides, it's the same DNA over and over and over again. And so you can imagine if you're thinking about it as a puzzle, it's really hard to put those pieces back together because it's all the same. So that is why also when you have these longer stretches of DNA, when you have these repetitive areas, it's easier to put it back together. Next slide. Here's an example of a sequencing workflow. So once we have a sample and we've collected it, and again, this can be sputum from somebody coughing up sputum, but we can also do sequencing on a bunch of other different sample types. So we can do it on stool, we can do it on a gastric aspirate, we can do it if somebody has had a lymph node biopsied or a sample of one of their lymph nodes taken, we can do it from that. They have also actually done sequencing on individuals' bone marrow. So they had a needle put in their bone and taken out, and we've done sequencing from that. So you collect your sample. If you need to, you can store it in a freezer for a certain amount of time. So if you're not ready to process your sample yet and get it ready for sequencing, you can store it. But when you are ready, you take your sample out and you do an extraction. If you're extracting from sputum or stool, there's different kits that you use. So you use a kit that is specific for that sample type. After that, you do what's called library preparation. So you take the DNA and you want to make more of it. So often you will do a PCR amplification of it if you are doing targeted sequencing. And then you like to put little, what I call tags, or we often call them barcodes, on the DNA. And this helps us recognize that the DNA is from a particular sample. So think of it that if I have 10 individuals that I'm going to sequence, I'll have 10 different tags that I clip onto each of their pieces of TB DNA from their bodies. So then I can tell them apart if I sequence them all at the same time. You also have to put a little piece of DNA on
It is
the
also more a massive
DNA
problem.
called an adapter. And this makes it so the sequencing machine can recognize, hey, this is a piece of DNA. I need to grab onto it and sequence. So library prep takes different amounts of time depending on what kind of sequencing machine you're using. And then you can actually load it onto the sequencer. And then some sequencers can take a couple hours to sequence your DNA and give you information. And then others can take 16 to 24 hours, so multiple days, to tell you what is the information it's getting. Next slide. Here's a more simplified version. So step 1, you extract your DNA. You take your DNA out of the sample using a kit. The second is you have your template DNA, so this would be TB. You do PCR to make more of those pieces of DNA when you're doing targeted sequencing. And then you have your little adapters, your little pink and yellow in this picture here, and you stick it onto the DNA. And then that helps the sequencing machine recognize the DNA and pull it into the sequencing. And you can also do different little tags, different markers on different pieces of DNA. So you can put multiple samples together. Step 3, put it on the sequencer. And then step 4 is analysis. I think analysis is the point at which people get the most nervous. There are some labs that have individuals that do the analysis themselves. So they take the files that are created and they interpret the data. But the nice thing is right now, there's such an interest in sequencing that there's a lot of software programs and a lot of automated analysis is coming out. So once you have your data, you put it into a system, a software, you push a few buttons and it will tell you information and say, hey, thank you for your files. These are the drugs that would work on it based on the mutations that we found. Or we didn't find any mutations. We didn't find any changes in the TB DNA. So any of the TB drugs that you would like to use would work for this individual. Next slide. So as I mentioned, there's a lot of different kinds of sequencing machines out there. These sequencing machines cost different amounts of money. And part of that is they do different amounts of data output. So depending on how much data you need, you can spend different amounts of money. So the first generation sequencing machines that came out there were Sanger sequencing. The second generation, you'll see Illumina is a very popular sequencing machine. And this third generation, we have PacBio and Oxford Nanopore. And these have different price points, and they also have different amounts of data that they can give you from the sequencing. Next. So as I mentioned, it's very exciting as we can do sequencing on many different sample types, whether this is whether this is direct sputum or stool. And then whole genome sequencing, when you look at everything in the TB genome, this can be done on sputum culture after you've grown it for many weeks. Next slide. So sequencing has come a long way since it was first invented. And I feel like each year sequencing is becoming faster. It's becoming more cost effective, and it's also becoming more portable. The sequencing machine that we're working with right now in my research is the size of a cell phone. It's very small. So you can easily take it from one location to another as long as you have a computer and the other lab equipment you need, which is very exciting. The United Kingdom has implemented the routine use of whole genome sequencing in TB diagnosis. So this is just part of a person has TB, they're going to get sequencing done. So this is very exciting that this is kind of becoming a little bit of the standard of diagnostic care. And it's because it's very quick. It can tell you a lot of information. And as technology is out there more, it gets cheaper, more cost effective, and easier for people to use. So it's very possible that someday we won't do any culture at all, that we won't have to wait those 1 to 6 weeks to get the information from a culture to tell us what drugs we can use. We all can just potentially use sequencing on the day the patient comes into the clinic and gives us that sample. Next slide. The WHO just this last year in July released a communication saying that they endorse it. They endorse the targeted next generation sequencing for diagnosis of tuberculosis. So this was very exciting that the WHO felt there was enough evidence for targeted sequencing to actually use it for diagnosing TB patients and making treatment decisions. And then I have to give a plug to our group. This is one of the research papers that we came out with where we're doing the targeted sequencing on stool samples. So as I mentioned before, for children, it's often hard to create for them to cough up sputum, but also for some adults, it's difficult. And it's also nice to have different types of samples to do testing on. And so we often do our targeted sequencing on stool samples, and this can give us some information. Next slide. The World Health Organization has made it a priority that we have access to rapid diagnostic tests, and molecular tests are a huge form of this. So we're getting more and more use of these rapid molecular tests, use all over the world, but as you can see, it's not in use everywhere. So this is from 2022, and we're still working on getting this implemented in many areas. Next slide. The WHO has put out a standard that they really want universal access to these rapid diagnostic tests. And this will allow us to have better diagnosis of tuberculosis in different areas and faster diagnosis of tuberculosis. Next slide. In terms of development of new diagnostic tests, WHO has also put out these core principles that are meant to kind of help guide development of these new diagnostic tests. And so they really want to ensure that diagnostic testing is equitable, that it's able to be accessed by many different countries, that the approach is patient-centered. So it doesn't put the patient under a lot of distress to get the samples or to do the testing. They want the testing to be rapid, and they want it to be accurate. There's no point in doing a test if it's not going to tell you true information. And then they also want it to be just useful. So it needs to be implemented in a way in a clinic setting or in a research setting that makes sense for that area. Next slide. So I'm happy to answer questions. Honestly, we could spend a whole lecture on each one of those particular molecular diagnostic tests. There's a lot that goes into them, but I was hoping this would give you a bird's eye view, an introduction to some of the diagnostic tests you might see about or hear about in the literature, and how they work and some of the limitations behind them. So this is our group that our group a couple of years ago. We definitely have changing team members, but we do a lot of work over in Eswatini. We're also based in Houston, and they're an amazing team to work with. And yes, I'm happy to answer any questions that you guys have.
Tara, that was really outstanding. You managed to digest a very, very complicated topic with few and direct words. We do have a few minutes time for a question, and I hope you will still be there to answer them. So please write your questions in the chat, and then I'll read them to Tara. So while people colleagues coming up with questions, for a setting like it is currently in Ukraine, what do you see is the most immediate future in terms of the use of molecular testing?
So I must admit I'm a little biased because I work a lot in the area of sequencing. To me, I think that is the direction that molecular diagnosis is going, is sequencing, because you can get the most information, the fastest, and the most cost-effective. And so I like to invest in things that are going to keep their relevance, that are going to stay useful. So I think that if Ukraine could start to invest in sequencing, there are many low-cost and portable options for sequencing that are coming out, as I mentioned. I think that would potentially be helpful. And we are trying to start working on that implementation and getting access to those things for Ukraine. So in one day, if a patient walks in with TB, you can get them the diagnosis and you can know what drugs would work. That, again, I'm very biased because I do sequencing in tuberculosis, but that is my feeling, is that is where the future is heading. And so it makes sense to do investments, especially when the investments are getting cheaper and cheaper into what's going to be used in the future.
So that sounds really very exciting. If you can give, here's Tatiana Sunenko. She has a question. Tatiana, can you unmute yourself? And
Yes, we can mute ourselves. We are sitting together, Tatiana and me, and Olga. Hello. Hello. Thank you very much, dear Tara, for such a nice presentation. And I think it's very, very difficult topic because it's quite not understandable for clinicians. But thank you. You did your best to explain us what is that. Next generation sequencing, I think it's our future. I hope so. And I wanted to say that for students and for all participants that maybe we will have our own nanopore Oxford device in our university lab. And I hope that we will be able to try ourselves, and we are going to participate in a workshop once upon a time in Lviv. I hope so. And I wanted to ask, if we use nanopore, for instance, such a new and good device, what are the requirements for laboratory for that? Would we use it in our clinical lab in the university, or we have to place it in the tuberculosis institution? Thank you for that.
Yeah, no, that's a really good question, Olga. And I know we have been very excited to collaborate and bring sequencing into Ukraine and taking those steps to do so. So thank you for being such a great and eager partner and collaborator. In terms of the equipment that you need, so for example, for nanopore sequencing, you definitely need to have a lab setup. You need pipettes, pipette tips. You need to have clean working areas to do PCR. So often you will need kind of a hood to do this. And you will need a few things like a PCR machine. You will need a small centrifuge at least to spin samples quickly. And then at least at this point, you need a high-powered computer. So it can be a laptop. You can do it on laptop, but it does need to be a powerful laptop to be able to do sequencing work. So those are some of the kind of basic things that you need. There are some smaller equipment that you would need, like, you know, a small magnet tube that is not too expensive. But, you know, this is something that with a few basic pieces of lab equipment can be done many places. I was talking to another researcher, and they are actually trying to set it up where you can do nanopore sequencing in a mobile bus. So having a bus with the equipment that can be driven around to different areas of the country to do sequencing. So I'm not sure how far they can get on that, but you know that the idea is that if you can have electricity in the bus, you could potentially do this, go pick up samples, run them that day, and then drive it to another. So you don't need a lot of space to do it, and just a few pieces of equipment.
So that also depends on the bus schedule. Ruoi Murakami has 3 questions, and I'm just going to pick the one in the middle. How effective is TB detection? Is there false positive and false negative with these molecular tests?
Yeah, that's a great question. So there absolutely are false positives and false negatives. If you think about it, you're in a situation where you have lots of samples in a laboratory. So it's very easy for samples to get mixed up. It's very easy for DNA from one sample to get jostled into another. And then sometimes with any test, the platform that's using can overcall. So you have to make sure that when you're testing, it makes sense to do the test. I wouldn't test TB in every patient that walks through my clinic. If somebody comes in and they, you know, have a broken ankle, I'm not going to do a TB test on them unless there are other things going on, like they tell me also they have a cough and they have a fever, then sure, I will test them for TB. But you have to make sure that when you're doing any test in medicine, it makes sense for that situation. Because if I come in and test somebody with a broken ankle for TB, I could get a false positive. So use it in the clinical situation that it makes sense, and then you can avoid situations of false positives as much as possible.
So Tara, if you are you are young yourself, so if you are a young person from Ukraine at the moment and you are considering what you are going to do when you finish with your university, what would be your advice in terms of going into research related to molecular diagnostics?
Tell them to email me and let's chat. No, but really the TB is such a fascinating organism. As I mentioned at the beginning, it has been around for hundreds of years. They have found evidence of TB in Egyptian mummies that have been buried in the pyramids. Like, it is absolutely fascinating that it has been around so long and it's still such a problem for us. So there is so much research to do on treatment and diagnosis and understanding why some people get TB and others don't. So it's an amazing area of research. There's a lot of work to do, and there's a lot of very sick patients that need our help. So it's a great area to work in, and many different ways you can work in it. So I would encourage you to reach out, get connected to myself. You can get connected to Olha, and we'd love to have some help in the field. We absolutely still need it. Still lots of work to do.
I think this is belongs to the famous last words.
I wanted to say once again, please, dear students or dear young researchers, if you are interested in the research in TB field, please ask us how to do that. We have several projects. You can help us, and you will be implemented into the research study. So if you want, please text us, text to my email. Please welcome. And if I see that we have just 5 minutes left. Зараз ми перевіримо чат. Чи є там питання в чаті у нас? Ага. Professor Lange placed the email of Tara in the chat. You can see, so you can text her personally, of course, or you can text us. Can we make vaccine for TB? One student asked, Nasir asked us.
Yeah, that's a great question. So many researchers are working on trying to make a vaccine for TB. There is one vaccine that's already available. It is the most used vaccine in the world, actually, called BCG vaccine. It is not perfect. It offers some protection for certain scenarios. So it offers good protection for children. And it also helps that if you do get TB, it is not as severe as it would be. But that vaccine has been around for over 100 years. And we still have a lot of TB. So it definitely has some improvements that can be made. So many people are actively working on trying to make a better vaccine. So we would love you to tackle that problem.
Thank you very much. And we have one last comment from Dr. Andrew DiNardo. He advised us learn how to code. So that is the advice for young researchers, I think, because we have first to understand how it works. So thank you very much, dear respected colleagues. Thank you, Tara. Thank you, Professor Lange. Thank you, Professor Mandalakas. Thank you, Professor DiNardo. Thank you all participants who joined us today. I think it was amazing, and I hope that we will fight TB all together. Thank you.
Tatiana, thank you so much, and especially a big thanks to Tara for really doing a great job. Don't forget to be there next week, same time. Gunnar Günther from Switzerland will guide you through radiology. It will be a really clinically oriented lecture showing how to interpret chest x-rays and CT scans. And we hope to see you again next week, same time. Have a good and safe weekend, and bye-bye.
Thank you so much.